Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Miss Catarina Angelo from Lisbon, Portugal. Dr. Angelo is a shoulder and elbow orthopedic surgeon based in Lisbon, Portugal, attached to the shoulder and elbow units of the Hospital dos Sams de Lisboa and Hospital Caftejo in Lisbon, Portugal. She completed a master's degree in medicine de Faculdade de Medicina de Lisboa at the University of Lisbon and her orthopedic residency in Centro Hospitalar de Lisboa Occidental. During residency, she completed 2 international fellowships in shoulder and elbow surgery in France and Belgium. She's an active member of the Portuguese Society of Shoulder and Elbow Surgery and the ESCA since 2017, also an invited member for the European Shoulder Associates. Since 2021, Catarina Angelo has also become an active member of the ISACOS and was invited to co-author a specific chapter of the ISACOS book about the role of SCR in failed rotator cuff management. She's a national international lecturer with several communications as invited faculty in national international events. In the last 5 years, she has devoted her work to clinical and biomechanical investigation in shoulder surgery, with several papers published in scientific peer-reviewed national and international journals. If you've noticed, Ms. Angelo has delivered a lecture on a channel in the past, and today is my great honor to bring back Ms. Catarina Angelo for this wonderful live program. Over to you, Anna.
Hi, Itesh, Loy. Thank you so much for having me again in this fantastic channel and to talk about this technique that we published recently, but we've been doing for some years. And we're very excited about it. So it's a pleasure, and it's very good for me to be here talking about this. And I hope that you will enjoy and share my point of views. So should we begin, Itesh?
Yes, please, go ahead.
Okay. So this technique that we described, it's called closing the circle technique. And this is a technique that is used for AC joint acute dislocation, not chronic, okay? This is the first thing that we should understand. So these are my disclosures. They are not really related to this technique or presentation. And when we talk about AC joint, we actually see that in online, in PubMed, at least on indexed papers, you get a lot of results and a lot of different techniques. So actually for acute AC joint techniques, you have more than 60 described techniques on the indexed papers, and it's getting higher and higher, especially with the advent of technical journals, journals that are devoted to the publication of technical techniques. And there is still no gold standard for the treatment of AC joint acute dislocation. So we all know these classical techniques. They are slowly being abandoned because they have a high complication rate, they have a high failure rate, and they need a second procedure for removing of the material that has been placed in the first procedure. So the orthopedic community began to think that maybe these techniques were too rigid, these fixation methods were too rigid, and maybe there's something missing in this kind of stabilization. So with the advent of arthroscopy and with the increasing of arthroscopical skills and instruments, new techniques have came up with for the treatment of acute AC joint dislocations, namely this suspensory system that it's arthroscopically assisted but still has an open part, and this will of course restore the vertical stability of the AC joint. So this seems very good, better than the classic techniques, but still the results report a high rate of loss of reduction, of subsidence of implants, and about 43% of residual horizontal instability after this kind of fixations. So maybe we should rethink this kind of techniques and this kind of technical stabilizations. So we start to think what really happened in an acute high-grade AC joint dislocation. So when we first look at it, what we see on AP X-ray, that's the first thing that we get from the emergency room, you get a proximal migration of the clavicle. So probably this is just a tear of the corticoclavicular ligaments, and the clavicle is pulled upwardly to the unopposed trapezius force. If this was true, this suspensory technique would be enough to restore the stability and would not have the high loss of reduction that has been reported in literature. So why does this fail? Why is this not enough to restore AC joint stability? And I put here the image of Knut because I wanted to thank him. I saw these videos here on Orthopedic Principles, a lecture done by him with Itesh a few weeks ago, and I found them amazing to try to transmit the kind of movements that the AC joint takes part. So AC joint, it's not a static articulation or joint. So when we want to restore it, we have to take into account that it has to be able to move in some kind of way. So actually, as you can see, the AC joint participates in the scapular motion, protraction and retraction, as you can see here. It participates in the clavicle translation, anterior and posterior, and it participates in the clavicle rotation, namely the posterior rotation of the clavicle when we abduct our arm. So in this fantastic study by Alex Van Tongel's group published in the JSM, the authors studied the abnormal kinematics of the AC joint when there's an AC joint with a high-grade acute dislocation. And what happens is that the clavicle motion is intimately correlated or related with the scapular motion. So it's connected by two parts. One is the corticoclavicular ligaments, and the other one is the AC ligaments and capsule. So the motion of the clavicle influences the motion of the scapula, and the motion of the scapula influences the motion of the clavicle, and this allows for a correct motion of the shoulder girdle. For this to happen properly, the AC joint must be intact, otherwise they will lose connection. So in this same paper, what the authors understood and concluded is that when you have a high-grade AC joint dislocation, which means that you have a break of the CC and the AC connections from the clavicle to the scapula, you break this kinetic chain of the shoulder girdle. So the clavicle motion and the scapular motion become not connected anymore. So you have a loss of rotation of the clavicle, you have a loss of strut effect of the clavicle, which is very important for the ability of putting your arm out there in space, and the scapular motion falls into protraction. So the scapula, when it's at rest, falls into a protracted position, which allowed the authors to conclude that maybe when you have an AC joint high-grade dislocation, it's not just the clavicle that goes up, but also the scapula that comes underneath the clavicle by this protracted and fold position at rest. So when we look at the AC joint, we should not just see a bidimensional structure. We have three main elements: the coracoid, the acromion, and the clavicular, and the clavicle. And these structures are connected in a coraco-acromio-clavicular complex. It's like a circle. And actually, as this is a three-dimensional structure, as you can see here in this video, we should actually call it a sphere. And to try to correct this sphere's breakage, we need to address this three-dimensional instability, but without compromising the motion of the clavicle and the scapula. So we need to reintegrate and to reestablish the stability of this articulation, of this articular complex, but At the same time, we need to allow some movements, otherwise this stabilization will probably fail. So as the orthopedic community began to understand more and more about AC joint and this multi-planar behavior of the joint and the complex, more techniques have come up in the literature that allowed for a biplane or a triplane vertical stabilization, as you can see here, with the buttons in multiple vectors or with this kind of construct around the coracoid. Actually, in this study by Park and colleagues in 2008, the authors concluded that when you add a posterolateral vector to the vertical stability suspensory system, you get a better AP stability when comparison to just doing the suspensory vertical stability system. Also, the stabilization of the AC joint has been highly studied in the last years. Many publications, mainly by the Munich group, Felix Dirna, Knut Beitzel, Frank Matschlager, they did a wonderful job in studying this kind of stabilization and in the influence that AC joint itself, capsule and ligaments stabilization have in the stability and horizontal stability, mainly of the AC joint complex. So this has been a leap in the treatment of AC joint acute dislocations, but there is still a lack of rotational stability reestablishment. So the rotational stability, it's not quite yet perfect. So this is why we kept on thinking about what we could do to maybe do a technique that could allow for some more motion, but without compromising this multiplanar stability of the AC joint complex. And we've been doing it for some years, as I said it, and we published it in Arthroscopy Techniques this year in March. It was actually published in July, we submitted in March. And if you want to read a little bit more about it, you can just scan this QR code. And this is an open access journal, so this will be very easy for you to access and to read if you're interested in the technique. So basically, what does this technique has that is different from the more recent techniques that are published out there? So we try to achieve a triplanar vertical stabilization. And in this triplanar vertical stabilization, we try to include this posterolateral CC vector published by Park and colleagues in 2018. And we tried to do a construction that allowed a loose horizontal stabilization and that was directly connected with the vertical stabilization. I mean, this is not two stabilizations separate, they are all interconnected. And this is why this is called the closing the circle technique. So this is an incomplete figure of 8. And this is the intent is to allow some translational and rotational movements on the AC joint, but keeping the center of rotation of the joint itself. So not compromising its stability. So this is a small video of the technique. This is just one case, it's an example. Of course, this is varies case to case. This was a grade 5 with a huge horizontal stability, as you can see here in this Alexander view. So we had a compromise of the coracoclavicular and the acromioclavicular structures. We do it with the patient in the beach chair position, and we always use a mechanical arm holder. This was one of our first patients, so the incision is a little bit bigger. Now we're doing it smaller. I'm going to show it next. If we can, we try to identify the delta trapezial fascia and for then afterwards to repair it. And as you can see, this is an open technique. We stopped doing the arthroscopical part, and we're going to talk about that later. We control it by fluoroscopy, and we use this 2.8 millimeter drill that's from the anchors. This is a null suture anchor. We put it both in the coracoid and using a fluoroscopic control. So these anchors, they stay underneath the coracoid and you have to arm them. They function almost as buttons. So when they arm underneath the coracoid, they will become a buttress. They will become a button, but that is not metallic, it's suture. So if as you're going to probably be able to read in our technique, we use one double loaded and one triple loaded anchor. We avoid the tip of the coracoid because that's the most fragile part of the coracoid. We come more to the back, and that's also more anatomic. And we use the same drill, 2.8. That's a drill that comes with the anchor. We use it to drill every single hole. So we put the two anchors on the coracoid. We drill two holes on the anatomic footprints or over the anatomic footprints of the CC ligaments, and then we drill the holes horizontally in the AC joint, as you can see here. Then what we're going to do is that we're going to use the limbs from these anchors that were placed in the coracoid to do all the construction. So this all will be connected to each other. So here we're passing one of the limbs from the anterior anchor, that's the double loaded anchor. And in this patient, we used this is a simple suture, but now we're using in this anterior anchor, we're using tape to do the AC part. So you can use it as a simple suture or you can use tape. And this is the different part of the technique, as you can see here. This suture comes from the anchor over the clavicle, enters on the back of the clavicle and goes forward. So this will push the clavicle down and bring it anteriorly. Then you're going to pass the remaining suture from the anterior anchor and one of the sutures from the posterior anchor to this medial hole, the lateral hole, I'm sorry, and the remaining two sutures from the posterior anchor through this medial hole. So this sounds a little bit confusing, but as you are able to see on the schematics, it's not confusing at all. And it's actually very easy and a quick technique to do as you avoid and you bypass all the arthroscopic setting of it. So you just pull it one by one. One trick that we do so we do not get to mix the sutures or the anchors before passing it on the tunnels is that we reference the anterior anchor with the nemostat and the posterior with the cocker. This is just a trick. So here, as you can see, we use the mechanical arm holder to shrug the arm and to help us reduce the AC joint while we tie the knots over the buttons. So 2 buttons. This is the only metallic part of this construction, are these 2 buttons. As you can see here, we put 2 buttons. We just press it down a little bit because we like to over reduce it a little bit, as it's been shown to be advantage in many papers. And then the last, we tie our loose figure of 8, open figure of 8 of our AC joint. And at the end, we unite them to close the circle, as you can see here. So after doing the stabilization, we test it. So we do the motions that put the AC joint in stress, and we see that the clavicle still moves, but it's stable. We do it also under fluoroscopy, as you can see here. So everything in place. And at the end, it's very, very important to try to close the AC capsule if you still have it. Some patients, it's like completely gone, but In another patients, you still have the capsule and the delta trapezial fascia on top of it. And as you can see, we close it in with an intradermal suture. Nowadays, we're doing like a 5 centimeter suture, so it's quite similar to the one that we were doing before when we used the arthroscopic setting in addition to the horizontal stabilization. So what advantages do this technique have in relation to the rest of the more than 60 techniques already developed for the treatment of acute AC joint dislocation? So the first and most obvious one, at least it was very different for us, was the lack of need of an arthroscopic setting. It's very cool to do arthroscopy. I love it. I think we all love to do everything or as much as we can in an arthroscopic setting. But in this case, we found that there was really no need for an arthroscopic setting. We only used it to check on the position and to pass the button underneath the coracoid. And as we began doing it with the anchors, we found no need to do it. And this is very cost saving and very, very time saving in relation to our previous technique. It's also less invasive for the patient, of course. With the exception of the lateral clavicle cortical buttons, this is an all suture technique. And our aim is to make it in the future an all suture technique without the buttons. But so far, we've been doing it with the buttons. And actually, as these buttons, or as the only buttons that we use in this technique are on top of the clavicle, if there's any problem, it's very easy to take them out. You do not need to go inside the shoulder to do it. It's a relatively easy thing to do, but we haven't had any problems with the buttons. When the patients have when they're skinny patients or they do not have a lot of muscular mass, they sometimes have problems with it, with the sutures and not the clavicle, so not the button, sorry. So probably what we're trying to do is to maybe tie the knots. We use a different kind of suture. It's called ribbon. It's less irritative and it's less protrude, just to try to minimize this small shortfalls of destabilization. Also, this technique has 3 different coracoclavicular points of fixation. So we have it's a multiplanar stabilization technique. So you address various plans in the vertical setting, also in the horizontal setting, as you've seen, and we aim to allow some motion and especially some rotation of the clavicle to allow a more physiological range of motion. The drill, it's a 2.8 drill. So when we do it separately, so we first drill the coracoid and then we drill the clavicle, this will allow us to choose where we want to put our drill hole. So when you use a guide, like in other techniques, you get to drill where the guide tells you to drill. So here you can drill whatever you want, because this is all suture and the suture will go in which direction you want it to go. So the fact that the clavicle usually is displaced posteriorly allows you a fantastic access to the coracoid. So you get to drill the tunnels in the coracoid very easily, especially you can palpate the coracoid very well. You cannot see it fantastically, but you don't need to see it. You can use the fluoroscope, and it's relatively safe to do this drilling. And then in the clavicle, you can drill wherever you want, and then the acromion also. So we aimed with this technique to address all 3 instability vectorial forces. And at the end, as this is an open technique, we can repair the delta trapezial fascia over the construct, as we know that this is also very important for the correct stability of the AC joint complex. Disadvantages, and I'm sure that some of you will ask me that. We do not go into the glenohumeral joint. How about the associated lesions? So this will not allow us, if there's any associated lesions, this will not allow us to see and treat in the same at the same time these lesions if we did not suspect them preoperatively. And the two tunnels in the coracoid, of course, are scary and may theoretically increase fracture risk. We fortunately never had a fracture of the coracoid using this technique, but as you know, it's a matter of numbers. I think that I hope that we'll never get one, but we'll see. Let me not jinx it. The fact that the drill, it's a 2.8 drill, so it's a low profile drill, gives us more confidence to do this drilling, two drill holes in the coracoid, and we always try to make them at least 1 centimeter apart, so not very close by to one another. Usually these patients are young patients, so they have good bone. And for those of you who do lateral procedure, you know that the coracoid, it's not, sometimes we wanted it to break more easily, but the majority of these patients, this is a good bone that it's difficult to break. This is some images of our first patient, and as you can see here, the incision was a little bit larger, but these were grade 5 dislocations. So as you can see, the vertical stability is very good, the horizontal stability also, and these patients are very satisfied. I don't have, unfortunately, yet a clinical study regarding this technique, but this will not last long because in the near future, we'll have our clinical results published out there, and then I will have a better slide regarding my results for this when presenting this technique. But so far, this is what we've got. So this is one of our last patients. So as you can see, the incision is getting smaller and smaller. Now it's very much alike the one that we did before. And this is the post-op at 3 months, the post-op X-ray. And this is all that I have for you. I hope that I was able to transmit why we developed this technique and why do we think that this can have some advantage in relation to the more than 60 techniques already published in the literature. Another AC joint repair technique, but we are really excited with it, and we think that this improved our patients' care in the last years. Thank you.
Thank you very much, Anna. Anna, you can stop sharing.
Okay.
Thank you, Anna, for yet another spectacular presentation, and congratulations for your paper as well.
Thank you so much.
Anna, now we talk a lot about arthroscopy, right? You're all arthroscopic surgeons. Now, why do you think in this particular procedure you do not do an arthroscopy and you go open? Is it your concern about leaving a larger carbon footprint? Because nowadays, a lot of surgeons are talking about green surgery. There's a green shoulder circle. You leave, I mean,
definitely
there are a lot of consumables being left behind. What is your concern?
This is multifactorial, you know. That's obviously a concern. I think that with the advent of arthroscopy and with the beginning of many techniques being done arthroscopically, with the better recovery time for our patients and the better addressing of the shoulder, this gave us a lot of confidence, and we want to do everything arthroscopically. And I love to do shoulder arthroscopy. But in this specific case, for that reason that you mentioned, the carbon footprint, of course, we are spending a lot of anchors, a lot of plastic materials that we use that are one-use plastic materials. If we do one arthroscopy just to look inside the patient and you do not even put one anchor, you're spending a lot, and you're also spending a lot of money in your hospital, and you're spending more time because you need to set up everything, the arthroscopy, the camera, blah, blah, blah. This takes time. I don't know how it is in your countries. The realities are very different. But here in Portugal, and I think that in some European countries, everything sometimes in the OR, it's really, really slow. And sometimes when you have an all OR day, you get the sensation that you spent a little time doing surgery and a lot of time waiting for your patients to be prepared and for everything to be ready for you, for the big moment and the thing that matters, that's the surgery. So that's another reason. But mainly because we actually thought that this was not needed. We did not need the arthroscopy. This was only getting in our way. So we started doing this. We tried in one patient that it went really well. And then we started doing it. And then slowly we just stopped doing the arthroscopic time in these patients. So the first ones with the anchors, we still did the arthroscopies to see how the anchors behaved, if they were like buttons, and it was amazing. And then we stopped with the arthroscopic time, and we just used the fluoroscope. We put it on the other side of the patient, and which also it's much easier if you do not have an arthroscopy tower on the other side. So there are many things that we have to take into account when we do a surgery to your patient. And I think that patients do not really benefit from the arthroscopic setting if you manage to do a technique where you do not have to control the position and to bring the button on underneath the coracoid under direct visualization, as some techniques are doing. But yeah, this is why we stopped doing it. It's multifactorial.
Thank you, Anna, for that. And Anna, do you think it'll be even more easier if we just get the coracoclavicular fixation with a Bosworth screw that has been described a long time ago? I mean, it's much easier to get a screw there, isn't it? And of course, you mentioned the additional posterolateral vector. I mean, that is something really great. So for the CC fixation, do you think a Bosworth screw is a very simple technique? Have you used that? And
it's very simple. I've never used it. I'm probably too young for it. I'm not old enough, because in Portugal, I think that it's in Lisbon, probably in Portugal, someone does it still, but at least in Lisbon, it's quite rare because it's a very, very rigid technique. And yes, it's a cheap technique. You just need a screw. You can do it. Usually, if the patient comes, you can do it in the same day because everything's there in the OR. But what are the costs, Hitesh? You're not really stabilizing all the AC joint, and you're putting something that's too rigid. That screw will not allow for the movement, the physiological movement of the clavicle to happen. And if it allows by loosening, it will break in time. Then you'll have a complication, and probably you'll have some metal inside your joint. And these are very young patients. They still have a lot of years to live, a lot of shoulder years. So one of the things that we promise when we become doctors is primo non nocere, do no harm. So we should think about the long time perspective. And now we don't even consider that kind of fixation.
thank you, Anna. Anna, we are also joined by Loy. Loy Al-Khatib is an orthopedic surgeon specialized in shoulder and sports surgeries and based in Dubai. Loy, your questions to Anna, please.
Thank you. Good evening. Thanks, Anna, for the wonderful presentation as always. And interesting technique that you're restoring or bringing the 3D stabilization for the AC joint. One of the questions that we were discussing today, I was talking to my colleagues there, guys, why you need to shift from using just a simple hook plate to this more costly or costly operation that costs you 2 anchors and drills and holes and so on. So in what, how can you convince the audience to shift from using a hook plate to your technique in fixing the AC joint?
I think that if I have not convinced them yet, I failed with my presentation because the hook plate, it's a good implant, but nowadays it's also, as the password screw, it's too rigid. You need to take it out. It violates the AC joint itself. So the AC capsule and ligaments, you ruin them. And then when you're going to take it out, you ruin them again. So you're doing something that goes against what you want to improve in your patient. So what you see in the X-ray, it's just a small part of the AC joint. The capsule, the ligaments, even for me, it's very difficult to understand the benefits of a hook plate, because even the violation of the subacromial space, I think that nowadays.
I'm not against or with, but this is just a third eye for the hook plate. This is the hook plate, you know, the longest follow-up term is using studies showing the hook plate and showed reliable results, right? So,
but Loy, you have to understand that when you get to cite
I'm neutral.
papers,
I'm just
But let me just put it into perspective. When we have the old techniques with papers that were published 20 years ago that have long time results, and they report good results, maybe low rate of complications and acceptable results. That's a very popular phrase in orthopedic literature. What is a good result? What were the outcome measures that they used back then? Even nowadays, we're struggling to unify the outcome measures to try to make a good result something that's homogeneous. And when you're going to cite papers that do not use patient-reported outcome measures that are validated and that can most of them do not even address the AC joint. They address the shoulder as a whole, or the quality of life of the patient, or they are simply questionnaires, or some of them just look at the AP radiograph, and then they see if they lose or not vertical stability in the AP radiograph. So we really have to be criterious when you're going to look at the results of very old procedures. Some of them are very good, but if something, we all know that this is not a perfect technique, the hook plate. Otherwise, we wouldn't be having all this discussion around AC joint. If this was a very, very good technique, we wouldn't need anything else. And I know there's a lot of pressure from the industry, blah, 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 but the hook plate, it's not nowadays, it's not the best option for these patients, in my opinion, and regarding what I just told you in my presentation.
So how would you revise if you fix your AC joint using your technique, closing the circle technique, let's say, and came back to you and it's failed? How do you revise it? Is there any strategy or backup plan for you, or how we would do it? It's still acute, let's say.
Well, for me, acute is 3 weeks. So if it's bad in this time frame, something happened during the surgery, or there's a fracture of the coracoid, or I don't know, something happened and I didn't realize it. Fortunately, this never happened to me. If this was in this short period of time, I would open, and first I would check what happened. And then I would try to correct it, of course. And I would be ready, of course, with other implants and but I would never, if your question is if I would use a hook plate, no. I would rather do a construction like a figure of 8 or a loop around the coracoid, or the only I would rather do 2 K wires through the AC joint and take them out percutaneously after 6 weeks than put a hook plate and have to remove it. Okay, awesome. I really don't.
That's the message.
Like,
okay, that's my message.
Yeah.
So any
I
tips?
Get it.
Yeah, any tips that this is scary? Just placing 2 holes, as you see, placing 2 holes in the coracoid. You might fracture the coracoid. Is there any tips or tricks that you use just to avoid fracturing the coracoid process?
Yeah. So the first one is, I already told you, that's leaving like 1 centimeter between holes. And this you can easily palpate with your finger. You do the first one. If you do the first one anteriorly, you try not to get too much to the back to still have space to put the second one. And you usually measure like 1 finger, that's 1 centimeter more or less, between the 2 holes. Another trick is to just wait. Do not force the coracoid. Just wait for the drill to drill, because this is hard bone. But if you force it, it will break more easily, as this is an apophysis. Okay, so just put the drill and then let it go slowly until you reach the other side. This is not. We never found any problem by doing this. And then when you hammer the anchor, just hammer it really slowly and try to be in the same direction, the same orientation as the drill. And this is probably technically the most difficult part of the surgery, because if you lose orientation, then the anchor will not get in, because this is cortical bone, it's hard bone. So you have to have the anchor in the same direction. So please pay attention when you drill. Even if you have to take the motor off and leave the drill there, just to really look at the orientation. And then only when you have the anchor by your side, you're going to take it out, or ask for your assistant to take it out, and then just put it and hammer it really slowly. And if it's in the right direction, it will slip really easily. And always control with a fluoroscope, because the anchor has to pass all
the way down.
All the way down, so that it can arm underneath the coracoid. If you not push it all the way down, this will arm inside the coracoid, and it's not that strong. We want both cortexes.
Nice. I think that's it, Techique. Okay, thanks a lot, Anna.
Anna, thank you so much for this brilliant presentation. That's all the questions that we have for this session. Thank you for yet another fantastic presentation, and congratulations once again for your paper. And we really look forward for more in the future.
Thank you so much for having me. I had a lot of fun, and I hope to see you too soon in the future in person.
Bye-bye.